Hi there, welcome to Sage Talks Medicine. Today we'll be reviewing a question from the renal section of Step 1 USMLE. Now, this topic is something that I've seen come up multiple times, and it can be a little confusing because it is timeline based. So let's just begin. So the question is, a 62-year-old man is admitted to the hospital following a ruptured abdominal aortic aneurysm that required emergent surgical repair. His preoperative serum creatinine was 1 milligram per deciliter. Over the next few days, his urine output progressively declines. And by post-operative day 4, he becomes oliguric with serum creatinine of 3.4 milligram per deciliter. A urinalysis shows muddy brown granular cast. Supportive care is initiated. On day 10, his urine output increases substantially, and by day 14, his serum creatinine begins to decline. Which of the following best represents the electrolyte abnormality expected between days 1 to 4 after injury? So you can pause the video here, look over the options, and come back when you're ready. Okay, so welcome back. Now the answer to this question is D. So before I go over the choices, let's first identify what this is even talking about. Now, the patient seems to be going through acute tubular necrosis. So what is acute tubular necrosis? Well, it's the most common cause of intrinsic acute kidney injury, or AKI. So basically, your tubules are getting damaged and they're falling apart inside. Now, they can happen based on two reasons. So let's go over that. Now, this is from our first aid book. So they can be caused by ischemia, so lack of oxygen, or even nephrotoxic injury. So ischemic can be secondary to less renal blood flow. Like, let's say there is a chronic type of heart failure. Um, or it could be due to something like pre-renal azotemia, right? Um, so lack of oxygen, and then it results in death of tubular cells that may slough off into the tubular lumen. So it shows up like this image right here. So the proximal tubule and the thick ascending limb are highly susceptible to injury. Okay, so those are the two locations in the kidney that are highly susceptible to ischemic injury. Another cause of acute tubular necrosis can be nephrotoxicity. So that could be secondary to toxic substances. So very common causes are aminoglycosides, so very important to remember. Radio contrast as agent, lead, cisplatin, which is an anti-cancer drug, ethylene glycol, uric acid in tumor lysis syndrome, myoglobinuria, rhabdomyolysis when your muscles start breaking down, hemoglobinuria. So in this case, nephrotoxic causes the proximal tubule are very susceptible to injury. So again, acute tubular necrosis, your tubules are falling apart. It can be due to lack of oxygen or if there's something that's nephrotoxic. Now, acute tubular necrosis follows a three-stage pattern. The first is initiation. So that's like right when the event happens, whether that's nephrotoxicity or ischemia, and there's an onset of tubular injury. Now that usually takes place within 24 to 36 hours. So like a day, 3 days. And then you have the maintenance stage. So at that point, you will experience very low urine output, so oliguria. You'll have volume overload because, of course, you're not peeing out the volume, and your urinary osmolality will go really low because um, you're just not peeing enough, and high urinary sodium, so you're losing a lot of sodium. Your kidneys are not able to reabsorb the sodium. They're not working properly, right? They're getting damaged. And then FeNAT, which is fractional excretion of sodium, it goes high. So that means you're not able to reabsorb the sodium, so a lot of it ends up in your pee. And then metabolic acidosis. So again, there's a high level of H plus ions, um, accumulation of acids because you're unable to excrete the H plus and regenerate the bicarb. And this will take several days, like 1 to 4 days. The last stage is recovery, and that's when your GFR actually improves. Like, your body is regenerating, your kidney, becoming better. And then you'll have a phase where you'll have transient polyuria. So you'll just be peeing a lot. Okay. So first it was you're not peeing enough. And now that, your body's regenerating, you're going to be peeing a lot, but the ability for the kidney, for the tubules to reabsorb the ions, it doesn't catch up, right? Like your GFR improves, but your ability to reabsorb the ions hasn't kind of caught up. So you end up with a lot of electrolyte wasting. So you're going to be peeing a lot of the important electrolytes. And then you have significant electrolyte imbalances, especially potassium. So you're going to have hypokalemia, but you'll also see low levels of magnesium, phosphate, calcium. So let's reiterate, initiation, not much is changing if you look at what's wrong with the patient. Then maintenance, you're not peeing a lot. If it's oliguria, on top of that, you're peeing out sodium along with other electrolyte imbalances. And then recovery is your GFR improves, you are peeing a lot, but your ability to reabsorb those ions has not caught up, so you're kind of electrolyte wasting. Now, this is just a table I got from UWorld, and it kind of goes over what I've talked about, so you can kind of pause and read it on your own time. But this is another thing that I always like asking the why, because the information sticks more. And all the questions, or most of the questions that I've seen, they always ask about the electrolyte balance during the maintenance phase. Okay, so again, potassium, what do you expect during the second stage? It's gonna be increased. So usually we excrete potassium normally, but your tubules are not working. So you're going to be you won't excrete it as much, so it's going to be higher than normal. And cellular breakdown can also leak potassium into the serum. Then you have phosphate. Again, you have increased phosphate. Same reason, you're not excreting enough. Magnesium will also be increased, impaired filtration and excretion. Urea and creatinine will be increased, and increased urea and creatinine, that term is azotemia. Again, poor GFR. Now, sodium is something you want to pay attention to. It could be normal actually, or it could be decreased. Um, Now, this one is normally we reabsorb sodium. So in this case, your tubules are just not working normally, right? So it could be due to the dilutional effect from water retention. Because remember, you're not peeing out enough. You have more fluid in your body. So your concentration of the sodium is diluted. And again, sometimes it can also be due to the increased tubular loss. And then you have calcium, so hypocalcemia. So remember we were talking about phosphate, right? So phosphate is increased, and usually what happens with phosphate is that phosphate binds with free calcium, and that will reduce the calcium in the body. And you also have reduced vitamin D activation in the kidney. And because again, the kidney is injured and it's not working properly, so you have low phosphate levels. And then you have bicarb. Bicarb is also decreased, and that explains the metabolic acidosis that we see in the maintenance stage. And then you have impaired acid excretion and bicarb regeneration in the damaged tubules. So let's go back to the question, why is D the correct answer? We have hyperkalemia. That makes sense. Your body is unable to excrete it. You have hyperphosphatemia, same reason, metabolic acidosis, and a normal BUN creatinine ratio. Okay, so let's go over the incorrect choices. Let's start with A. So A is incorrect. Let's go. Um, Hyperkalemia we know can happen. Metabolic acidosis can happen. Hyponatremia can happen in ATN. But the one thing that's wrong is the increased BUN creatinine ratio. So you can pause here for a second and let me know where you could see this instead. So increased BUN creatinine ratio is actually seen in pre-renal acute kidney injury. So let's say there is some kind of heart failure and the kidney has lower blood flow. And so there's hypoperfusion, activation of RAS. And what happens is there's nothing wrong with the actual kidney and its absorptive capacity. So it's gonna start reabsorbing so much more, just so it's panicking basically. So it's gonna be reabsorbing sodium, water, urea, that's BUN, and so the ratio actually increases. So you have much more BUN in relation to creatinine. So your ratio ends up being more than 20 to 1, and usually it's around 15 to 1. And so in ATN, on the other hand, you have tubular damage, and so your kidneys are cannot reabsorb as much. So urea, the reabsorption is not as efficient, and creatinine also builds up, but together they're kind of rising at the same, like in the same amounts, in equivalent amount. So the ratio itself is going to be normalish, so 15 to 1, or even a little low. So going back, this is what it makes this option incorrect. Now, B, hypokalemia, hypocalcemia, low bicarb due to osmotic diuresis. So you're peeing out more. This describes the recovery stage of ATN, right? Because you are electrolyte wasting and you're losing pretty much everything due to polyuria. So B is incorrect. Now C, you can see it's normal potassium. We know that it is hyperkalemia. I've said this a million times during this video. So hypophosphatemia and hypomagnesemia could happen, but again, it happens later on in the timeline where you'd expect to see more changes with potassium. So that's incorrect. And the last one is just a distractor because hypokalemia, we know that's incorrect. Metabolic alkalosis, no, we see metabolic acidosis. Hyponatremia could be seen. This one again, elevated serum creatinine. Um, it's an incorrect choice. So I hope I broke this down enough for y'all where you can see the ion changing and the electrolytes changing. Just think of it in terms of the stages: initiation, no change; maintenance, you'll see a bunch of electrolyte changes. Just remember sodium, calcium, bicarb, those are the only ones that are either staying normal or decreasing. Everything's increasing. If you want to remember the reason, you can come back to this table if it helps the information stick better. And then finding recovery, you're peeing a lot and you're wasting all these electrolytes. So I hope you found this helpful. When you're doing questions like this and reading explanations, it can get kind of confusing. I like to make my videos very simple to understand, and I repeat a lot so that it sticks in your brain. So when you're writing the test, you can answer it really easily. So I hope you like this video about acute tubular necrosis. Let me know in the comment section below if you have any other topics you want me to tackle. And I hope you all have an amazing day studying and staying productive. Take care.